The orthoPAC podcast, hosted by Sam Dyer, Chuck Dowell, and Miles Gilbreth. Welcome to the orthoPAC podcast, where we attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, listeners. Today we have another panel discussion with Chuck and Miles, and we're talking about when can we return to sports. Let's talk about something we haven't talked about. What about spine stuff? What about lumbar strains, or if somebody has a herniated disc, or what about somebody that, we talked about cortisone injections, but what about an epidural steroid injection? So those are three things. And those are a little bit more tricky because, in my experience, a little bit more tricky, meaning that it varies. Some people within a week are much better after a lumbar strain. Some people it takes longer. Some people it takes a couple of days. This is one of those things, having much experience with this, unfortunately, personally, it just depends. So I'm curious what you think. Let's take two instances. We have middle-aged, somebody who is, the couch to 5K versus somebody who is regularly running, 20, 30 miles a week, and they have a back strain for whatever reason. What do you do? What do you say to those folks? How do you tell them about getting back to their activity?
Back strain, lumbar radiculitis, degenerative disc disease, lumbar facet joint pain. I pretty much have the same script for low back pain. There are four ways we're going to treat this: medications, exercises, injections, and surgery. Only 5% of people will ever need surgery, so let's throw that out the window. Then I look for the visible reduction in anxiety from the patient when I've said surgery and then completely said we're not going to talk about that.
Oh, wait, when you throw the S word out there, buddy, you better be coming with it. So.
Oh, yeah. But that's where it follows up. Only 5% of people will ever need it, so we're not going to talk about that. This isn't you. And 9 times out of 10 for low back presentation, that patient will not end up needing surgery. I then drop down the list and go back to injections, which is talking about epidural injections, facet joint injections, you name it. Before we do that, we would need an MRI, and it takes some time, unfortunately, for insurance to approve that, typically 6 weeks of conservative treatment. And for good reason, because most people really do get better with that conservative treatment. Medications, NSAIDs, muscle relaxers, gabapentinoids, oral steroids, injectable NSAIDs, injectable steroids, in conjunction with structured physical therapy. And that's where I kind of leave it open of, hey, I want a physical therapist to help guide you back to your activity, right? There are definitely things I want you to avoid: squats and deadlifts. There are definitely things I want you to do: walks daily, core strengthening in the form of stabilization, such as planks or farmer's walks, and stretching your hamstrings. And so that's kind of my nitty gritty script as to how I initially approach low back presentation of all kinds. Obviously, the way I counsel them on what's going on differs based off their given clinical presentation, but that's kind of my go-to script.
What do you think, Chuck? What do you tell folks about getting back after the back strains?
I mean, I would agree with Miles. I think that's definitely how I approach it, very similarly regarding kind of treatment options. I think the big thing to advocate, and this could be my athletic training background, is movement is important. We know that the literature shows that sitting on the couch and doing nothing and not moving will not necessarily help your back pain and will potentially make it significantly worse. I think movement is important, getting up, like Miles said, and doing some exercises. I tell them to get up once an hour, move around. I like heat better than ice. I think therapy can be quite helpful in a lot of the situations because it can kind of encourage them to move and can allow them a progression back into their sports related activities. Again, that marathon runner that's doing high volume running and, has a low back strain, potentially, again, because as we've talked about before, their core strength may be better, their back strength may be better, their posterior chain, neuromuscular control may be better. They could potentially get back to these activities a little bit faster because they can regain that a lot quicker, and maybe doing some cross training for a short period of time to allow the reduced impact on their back, the reduced stress and strain on their back. But they're somebody that wants to be active. And so I try to give them exercises in clinic that they can do to be active to potentially get it better quicker. The couch to 5K patient, again, I think maybe is going to progress a little bit slower, but I still want them up. I still want them active. I don't want them to lose the gains they've made. I just may counsel them that it may take a little bit longer to get better. But Also, soft tissue injuries are so unpredictable. I think that's an important thing to counsel all patients on, that they could take 2 weeks, they could take 2 months to get better. It's very individualized by each person and the way they heal and kind of how they recover from things. So it's a very unpredictable thing to discuss with patients, and I try to be upfront with them about that as well.
I agree. I think PT is a huge part of back strains, if that's what you think, or the degenerative changes or whatever, or even the H&Ps. I think the therapy is a huge part. But returning to sports, it just depends on how severe it is. I mean, you really want to get people active and get them moving, but you don't want to be too aggressive, I think, and set them back. So having physical therapy help you is a critical part. Just like a lot of these things, if somebody's really motivated, like I have to get back, I've got this major game or this major contest, whatever coming up. Well, the best way that I know to help you to get back, I can give you these home exercises to start, but you need to be in PT. And PT can really help you get back, and you need to sell that's a big part of their recovery, and that'll help you to get back. So I agree. I think PT is a huge part of getting back to athletics.
I think also, in addition to that, making sure that, I always think about what's the cost burden to the patient, right? So I give that patient the option of, hey, you can go to PT 2 to 3 times a week for the next 4 to 6 weeks, or you can go once or twice, get a home exercise program, do it, because you have to do the home exercise program, and then go to PT on a more PRN basis. Another thing you mentioned, Chuck, you mentioned liking heat more than ice. And I think that's a conversation that I have 3 to 4 times on a daily basis. And I kind of try and just lay out the option to the patient. I say Western medicine, which is about 100 years old, has always really heavily relied on ice. Ice is a vasoconstrictor. It reduces blood flow. It can help with acute swelling and acute inflammation. On the flip side, heat, which has been more heavily relied on in Eastern medical traditions, which are thousands of years old, is a potent vasodilator. It brings blood to the area. It can sometimes increase pain, but that blood that's coming to the area is also bringing the healing aspects that our body naturally produces to the site of the injury. You can do ice, you can do heat, you can do neither. You can do whichever one works for you. You can alternate between the two. And I leave that ice versus heat decision very open to what feels better for that specific patient.
Yeah, I think whatever feels good, do it. I mean, I'm not married to either one. There are ideas behind each one, but then you explain all that and somebody says, well, this one works better. Okay, we'll use that one. I mean, I don't care. It's going to get better. Just, whatever feels good. But the rule of thumb is this or that, like you said. Okay. Listeners, please follow up next week for a continued discussion on when can I return to sports.
Listeners, I hope you can join us at one of our upcoming CME meetings. We have our musculoskeletal ultrasound workshop from February the 28th through March the 2nd in Charlotte this year. We also have our Ortho in the West annual conference, March 28th through March 30th. Look on PAOS.org for details.